Thank you, Richard, and welcome everyone to our Webinar Wednesday series. We've conducted over a dozen of these events dating back to the spring of last year. And this particular topic, building a comprehensive lung program, is not only near and dear to my heart, given my role as the Director of Market Development, but it's also a subject matter that presents an opportunity for all of us to make a meaningful difference in lung cancer care. At the end of the day, I think you'll find that the areas of focus as you build out a comprehensive program are going to fall into one of three categories. And if you can advance to the next slide, Richard, and that would be clinical, economic, and operational. Our guest faculty this evening has spent over a decade developing the program at his health system to where it stands today. And he too would agree that, although there's no canned approach or set in stone guide to follow, there's some fundamental elements that you'll need to consider as you draft plans at your particular facility. So with that, he's going to be sharing with us this evening best practices and lessons learned over the years, strategies that they deployed that support the entire care continuum from screening to incidental nodule management through survivorship and long-term care, as well as key players that need to be engaged to successfully operate a comprehensive lung health program. So next slide. This QR code, there it is. This QR code and this slide will appear again at the end of the program. So you can either take a moment now and take a picture of it with your cell phone, if not later in the program. But at the end of the day, we value your feedback and we would love to hear from you, if not after the program, sometime tomorrow, just to give us feedback on what went well and what needs that were still not addressed. So at the end of the day, future programs will ultimately be at their best. Next slide. So without further ado, I'd like to introduce tonight's guest speaker, Dr. Bobby Mahajan. Bobby is the medical director at the Anova Interventional Pulmonary and Complex Airway Disease Program at Anova Health Systems in Fairfax, Virginia. Not only a great guy, but someone I have a ton of respect for, given his commitment from a programmatic standpoint, not just clinical, but from a programmatic standpoint in building out what is today a best-in-class lung health program. So thank you all for joining, and I now turn it over to Bobby.
Thanks, Tim. I really appreciate it, and thank you for giving me the opportunity to speak today. I was as well dressed as you at one point today, but then I had to run to coach soccer practice for a little bit. So I'm doing this out in nature to make it a little bit of a better background compared to everyone else. So first thing I'll start off with is honestly just giving an overall picture of program growth and financial sustainability. And I think that when we talk about program development, we often think about doing procedures. And while that is one of the, kind of the tenets of how we develop a program, it really isn't related as much to program growth. Because again, at the end of the day, as interventional pulmonologists and advanced bronchoscopists, we want to be able to offer a service as opposed to just do a procedure. And not only from the beginning of that, seeing those patients, but also the follow-up is really part of developing a program. Next slide, please. So these are some of my disclosures. The only one relevant today, obviously, is Medtronic. Next slide. So I think that one of the first questions coming out of fellowship 7 years ago to develop an interventional pulmonary program at an institution that had never really seen interventional pulmonology or advanced bronchoscopy was, what can we really offer our patients by developing a program, especially when there's a gap in care? And I think that this is the biggest question we run into whenever we start a new program, or not even necessarily a new pulmonary program, but also any kind of new practice program, whether it be a lung nodule program, lung cancer screening, anything of that nature. And I think that the challenge is we always say, well, we want to be able to be successful, but really when we talk about success is to be able to fill a void that exists. And that's really how we look at what we can do for developing a program. Most of the time, our job is to justify our existence to a lot of administrators. And honestly, by filling that void, we're able to justify that kind of need and ability to develop these kind of programs as an interventional pulmonologist. Next slide. So, there's two parts I talk to about any new IP doctor coming out, a fellowship, or anyone who wants to develop a new program, whether it be, like I said, incidental lung nodules, lung cancer screening, or a complex airway disease program. The first step is having a clinical plan. And again, that doesn't have to do with, oh, I want to do procedures. Again, that has to do with what kind of disease processes do you want to address in terms of identifying and, again, being able to help other physicians in doing so. And the second part is economic justification. So this is a huge part of what we do from an interventional pulmonology standpoint, but this is involved with any kind of program we do, whether it be GI, interventional pulmonology, cardiology. Unfortunately, based on what we do as interventional pulmonologists, regardless of what the benefits we provide, and honestly, the downstream revenue we show, we always have to be able to sustain what we do financially. And I think most of us are really focused on the downstream side, but frankly, bronchoscopies in themselves are positive when it comes to a contribution margin. They do make money. Now, frankly, they make money for the institution. They don't always make money for the physician because professional fees really aren't, all that robust. But really what we have to be able to show our institutions is that by having these kind of programs, it's worth it to them. Meaning not only is it beneficial for patient care, but it can make money so that we continue to expand them and grow them over time. Next slide. So, when we talk about economic sustainability, these are the things that we lack in general. For all of the education we've done, whether and many of the people on this talk, if you're physicians, have family members who've said, "Look, aren't we done with education?" Well, the idea is that education never ends, and many of the things that we try and learn on a regular basis in the real world with regards to pulmonology, we were never taught. So, we are really poorly prepared when it comes to actually talking the financial kind of lingo associated with medicine, while our administrative partners in our hospitals are very versed in it. And if you can't have that same conversation with the same kind of vocabulary, you can never actually be on the same plane as them to explain why you're doing certain procedures and what kind of programs you're building. The second part is how do we work with those administrators like we talked about. I'll talk shortly about different terminology and how they pertain to interventional pulmonology and profits and losses like direct costs, indirect costs, contribution margins. And finally, this is really a business aspect. Unfortunately, we are very good in the medicine field of understanding what it's right to help people, but we have to be able to show that us helping people can maintain not only health and clinical improvement in patient care, but also it grows the program. Because as many times as people say, "Oh, well, I just want to help patients," of course, but in the real world, we have to be able to run these different programs economically to be able to provide clinical sustainability. Next slide. Next slide, I think. Let's see. So I had the benefit of being at a number of institutions which had either early interventional pulmonology, actual advanced diagnostics, and then kind of well-organized interventional pulmonology programs. So, a number of people at these institutions like Kyle Hogarth, Eric Folk, Adnan Majid, were all at different kind of phases of their career when I was there, in the sense that Kyle Hogarth was doing advanced diagnostics at University of Chicago. Adnan Majid is where I did my interventional pulmonary fellowship, had a very organized and well kind of oiled IP program. And Eric Folk had just moved over to Mass General Hospital at that time when we started rotating there. So, I was able to have the benefit of taking all the pieces of these different kind of programs and seeing how they work to integrate them into what we do at Anova Fairfax, which is, again, a community hospital, albeit a 1,200 bed hospital, but again, community nonetheless, not associated with a true academic center. So by taking little pieces of each of these institutions, I was able to put together what we have now at Anova, which is a hybrid kind of version of academic and non-academic settings. Next slide. And like I said, Anova is really a 5-hospital system in Northern Virginia, and is just outside of DC, about 10 miles. Next slide. And, when we talk about what the capabilities of this hospital were, now we have, in the adult hospital, 920 beds with another 200 or so in the children's hospital and women's hospital. It has thoracic surgery, interventional pulmonology, lung transplant and surgery, and medicine residency. The one thing that didn't exist when I got to the hospital 7 years ago was interventional pulmonology. The extent to which we had at Anova Fairfax was a bronch suite that did about 10 bronchs a week, most of which were really only flexible bronchoscopies for transplant patients. We had occasional BAL for patients who are immunocompromised, but really we didn't have much of a footprint in the Northern Virginia area. Next, and really the reason for that, I'll be honest, was that it wasn't considered sustainable economically or from a clinical standpoint. We said, oh, well, we can just send our patients over to Hopkins or VCU if we had those advanced problems. But in order to develop a cancer center and a cancer program in Anova, we obviously understood we needed to have more of a diagnostic kind of approach and therapeutic approach when it comes to lung cancer. Next. So there's a couple things we had to do to set up the service line. First of all, we had to make sure that we weren't, kind of biting the hand that feeds us, especially from a thoracic surgery standpoint. So we actually, as opposed to jumping into the pulmonary service, we became part of the thoracic surgery service. And we were able to fill this clinical gap. The clinical gap we were able to fill initially was just with diagnostics through endobronchial ultrasound to actually stage lymph nodes, to biopsy lung nodules. And then we brought in therapeutic bronchoscopy, rigid bronchoscopy, and treatment of airway obstructions. Really where we were able to move that into was incidental lung nodules and lung cancer screening, which I'll talk about later. And honestly, we had to identify which patients were, physicians were best suited for procedures. So this was not a very fun part of a program development. Which was quality control and trying to tell people that if their quality wasn't to the appropriate level, they really wouldn't be able to do certain procedures, or their actual procedure capabilities would be limited, which honestly, over the long run, it did take a few years. It actually was well embraced, not only by physicians who are doing those procedures, but also by the administration who was providing the resources for those. After time, we were able to develop a number of different programs, including lung cancer screening, incidental lung nodule program, and bronchoscopic lung volume reduction. Okay, next slide. So who are the key players? I think this is pretty well understood, but I think more importantly, it's playing nice in the sandbox. Medical oncology, obviously, radiation oncology, critical care services, general pulmonology, lung transplantation, anesthesia. The most contentious kind of group here, surprisingly, are the other pulmonologists, mainly because obviously the pulmonologist and an IP or procedural program coming in, there's always a risk of cannibalization or stealing patients. And when you're developing these different kind of procedural programs, the goal is not to say, well, we're going to be competing, but we're going to provide an adjunct service. So in a lot of ways, when we had the general pulmonologist, the way we were able to encourage them to use our bronch suite and refer to our myself and the IP program was to tell them, look, we have no desire to be involved with general pulmonology. We only want to do the procedure and then hand the patient back to you. But what they were able to see over time is that they were spending less time in the bronch suite as we could do a procedure much faster. And secondly, the quality of care and the availability of different services is always available. Next slide. And so, how we developed this was in slow order. The first thing we did was provided the new service of treating complex airway disease, including airway obstructions. The next, what we kind of honed was our EBIS capabilities and navigation services. Next, we moved to pleural disease. Now, I'll tell you, no one wants pleural disease and no one wants to deal with it. But one thing I found from IP is that if you do things no one else wants to do, you can be very successful. So we were able to develop this service. And in doing so, we were able to do, obviously, thoracentesis, chest tube placement, tunnel pleural catheters, and now almost more recently, medical thoracoscopy. The lung transplant service was available, and which only kind of added to the lung transplant capabilities and the team by saying, look, we can handle those airway complications or the different kind of surveillance bronchoscopies need to be done. In the more recent, past, the last couple of years, we've now developed bronchoscopic lung volume reduction program, and we've been able to focus on programs like lung cancer screening and our incidental lung nodule program. I think that really what we've seen towards the end of this process has been more so, as opposed to trying to do all the procedures, which is what we really did at the beginning, was saying we're going to do hundreds of procedures a year, graduating up to thousands of procedures a year. The procedures, again, aren't a program. They're the capability of providing a service. The program is really organized by bigger pictures, such as lung cancer screening, incidental lung nodules, which has really been providing a better service to our patients on a larger scale, rather than just doing individual procedures. Next slide. So this is kind of, I want to give you an example in our first 4 years of what we did with regards to surgical volume, pulmonary services, and how it improved. Now, I'll say that most people in especially community hospital settings and even academic centers say, look, bringing in an interventional pulmonologist isn't always good for our thoracic surgeon. And part of that is because some of the procedures we do are overlap with thoracic surgery. And what we saw in our first years was that our surgery cases with the IK, this is what our surgeons had done in their practice, saying that they did a ton of surgery cases that you see in the blue, but in the green, each year their number of IP cases went down. And at first you would think that was a bad thing, meaning you're doing fewer airway procedures. And again, first of all, the surgeons aren't great at doing these airway procedures in the first place because they're trained to do surgery. But what we did see, next slide, was that as the number of cases that were bronchoscopic went down, the actual movement of the surgeons in terms of the type of cases they were doing, the surgery cases went up. Actually, they were doing more VATs, they were doing more surgical resections and lobectomies. And as a result, the amount of cases that they wanted to do went up, and their revenue actually went up. So by taking those cases away from them, it allowed them to do more of what they were trained to do, and honestly, things that were more positive from a contribution standpoint regarding their practice. And on top of that, we were able to do our bronchoscopic cases as well. And how did we change that shifting volume? We're able to do that by moving number of our procedures out of the operating room into the bronchoscopy suite. Like I had said before, we were using about 10 bronchs a week in the bronchoscopy suite. And by organizing this, having a full team of RTs who are only doing IP, we've currently moved up about 40 cases a week, most of which are advanced cases. IP procedures are doing by the most skilled practitioners. It's always great to have someone who wants to do EBIS, and they spend about 2 hours doing EBIS on one case. But if you're able to have people who are more proficient in this, as opposed to doing one case in 2 hours, there's a capability of doing 3 cases in 2 hours. So we were able to say, well, who are the most proficient in doing those procedures? And those are how we should be able to take care of patients, giving the person who's best at doing the procedure, not the person who's just capable of it. And last, playing nice in the sandbox is important. There's no situation where physicians should be criticizing other physicians, but there are situations where we should be improving efficiency in patient care. And there are ways of doing that without being malignant as well. Next slide. So this is kind of the basic understanding with regards to some of the discussions we had with our administration. Now, first, when we came in, we said, look, we can do all these procedures, and that's how we built up the program. But in relaying the sustainability and the success of the program, we had to be able to show them what we were able to do and what we were capable of. So the first thing we looked at are the two most important factors with regards to profitability and sustainability of a program is first, net revenue, second is direct cost, and last is contribution margin. And if you look at these kind of pieces, if you look at net revenue is what you really collect from a patient after a insurance reimbursement. Direct cost is the amount of cost it takes for a procedure to occur, such as if we're talking about doing a bronchoscopy, the amount for the disposables like the forceps, the EBIS needle, that is, and even the personnel such as the nurses or RTs, those go into the direct cost. And finally, the difference between the revenue that was achieved from the insurance company minus the direct cost, or the cost it took to run the procedure, is when you see a contribution margin, which is really what the facility or the institution is collecting at the end of the procedure, and what we see as profit. Next slide. And this is kind of what we ended up seeing. If we look at this as a kind of a breakdown of the total revenue, people often don't realize that what you get, what you submit to the insurance company is not what you receive. So for example, if we end up charging an insurance company $10,000 for a bronchoscopy, in general, Medicare typically will reimburse 1/3 of that, while private insurance will reimburse anywhere between 40 to 50% of that. So the net revenue is not the amount that you charge, but the amount you actually get compared to what was charged. And from that, a number of costs are incurred, such as the different supplies, the medications, anesthesia, all of these things. And that's what comes out and what we use for the costs related to the procedure. Now, there are indirect costs as well, which we don't consider really relevant, because the indirect cost is how we run an institution. For example, the cafeteria, the janitorial services, upkeep of the grounds, those are indirect costs. So those get distributed differently. We don't really consider that as part of the procedure. Next slide. But this is kind of an example of what we end up seeing in the different codes related to these different payments for each of the different bronchoscopic procedures. If you look at the bronchoscopy with markers, EBUS 1 to 3 nodes, bronchoscopic dilation, this is what the final payment rate in 2019 was. So as you see, just putting the bronchoscope in there is about $480, but doing more advanced procedures is where we actually see revenue. Now we subtract our direct cost from that, and that's what we see from our revenue for these patients, or the contribution margin. Next slide. And this is kind of the full breakdown. So for example, if we look at commercial and Medicare, if we charge $1,200 for a bronchoscopy, we get reimbursed, which is much less, $2,500 or $4,000, and we subtract our direct costs. The contribution margin is really what we see, that $500 in Medicare or that $2,000 in commercial. Now, this is extremely powerful data to talk about, because honestly, if you have this data down, those three terms, the understanding of what your administration and C-suite does is completely covered. These are the three main things they look at with regards to success and sustainability of a program. So even if you would just come out of this saying, look, this is the contribution margin for each case I do, you sound like a superstar to your C-suite. And in all honesty, this is available readily in every hospital with their accounting department. First of all, accounting, no one ever goes down there. So if you visit them and talk to them, it'll be like, frankly, it's better than sliced bread in a lot of ways, frankly, because they never see anyone, and able to get this information and show this to your administration really does show that, frankly, even though you're losing money on certain service, bronchoscopy does make money because there's so little involved in direct costs. One of the challenges is when we want to do these bronchoscopies in an operating room setting, the direct cost related to that compared to a bronchoscopy suite is extremely high, anywhere between charging about $180 to $190 an hour in an OR, a minute, versus close to $6 in the bronchoscopy suite. So understanding how to trim your direct cost is the most important part of reducing your direct cost and improving your contribution margin. Next slide. And again, this direct cost that we look at, as you bring down your direct cost, you're going to see improvement in your contribution margin or the profit margin. Again, I think that there's only so much we can reduce when it comes to ensuring patient safety. But if we can ensure patient safety by still doing and reducing our direct costs, is where we find true improvements in our contribution margin. Next slide. Again, last example, and this is the most important slide with regards to kind of a financial and economic sustainability, is understanding your contribution margin. Meaning that if you reduce your subtract your direct costs and your net revenue, you'll see what the contribution margin is. If that's positive, obviously that is going to be showing your administration that this is a worthwhile procedure or program to continue to enhance and support. If it's negative, it really means that you have to find a way to be able to do this with less cost. Now, that being said, some procedures and some patient care aspects are negative. We just have to accept that and be able to show where you can make positive contributions with that. And typically that comes with downstream revenue. Next slide. Indirect costs, I don't want you to worry about too much. Really what this is associated with are costs that are incurred by the institution, not costs that are related to the procedure. Next slide. Next slide. And again, opportunity cost, return on investment. These are important, meaning that where are we able to do these procedures where there'd be less charge versus your return on investment. How many of these procedures would need to be done in order to make up for the cost? Next slide. These are the components you have to look at, and this is what we looked at in terms of utilizing our, for example, our incidental lung nodule program. Once we had a little bit more volume under our belt, we were able to say, look, what are we able to look at the downstream revenue and the resource? And what we were able to do was take these incidental lung nodules and honestly reduce the traffic it took to get to the right place. For example, most of the time what we ended up seeing was that patients would get identified as an incidental nodule, sent to their pulmonologist, oncologist before they actually got to the biopsy. With this, by putting in a direct cost of a lung navigator, we were able to increase the number of clinic visits and identify more cancers more quickly. Next slide. All right, guys, count of 3 phantoms. And this is what we saw again with those surgical volumes. By instituting this program, we went up in our volume of bronchoscopies and went up on our volume of VATs. And as a result, there were higher sustainability and more profit for the hospital. Next slide. Now, again, what we run into also is capacity constraints in terms of interventional pulmonary programs. As the numbers have gone up, we've had to put more investment in terms of cost, but with regards to growth and building a new center. As a result, we've shown that these costs are essential in increasing the volume, increasing the contribution margin. As a result, we're building a new space to make up for this increase in volume. Next slide. And this is a kind of an overview of some of those key health terminology. It really does make a huge difference if you're able to master these. Discussions with the C-suite showing how profitable and sustainable and successful your program is very easy. Next slide. And measuring the shift, and this is what we ended up seeing from a volume, not only a volume change, but also for a profit contribution margin in regards to shift in VATs. Because we're able to do more procedures in the bronchoscopy suite, making thoracic surgeons do less bronchoscopy and more VATs, there's an increase in the VATs percentage, and as a result, an increase in the volume and contribution margin of over $1 million just by bringing in interventional pulmonologists. Next slide. So these are important in order to understand and show your sustainability. But overall, I think that what we can show is that it's essential, but understanding how growth occurs and how to explain your growth and show them through appropriate economic means is part of showing growth and building a program. Any questions?
If nobody has one live, Bobby, I've got some that came through as the moderator.
Sure.
I can see on chat that I can throw at you. So
Yeah.
I'm going to paraphrase. This question actually came up twice. You spoke a lot about financials and building on a program, and it says, thank you for that. What are the most impactful things a hospital can invest in when it comes to lung health? And they also add specifically in the areas of technology and staffing. So, you think about how expensive an FTE is or getting that next technology in, what are the most impactful things that you think that you need to build
I think there's two parts to that. The first part is obviously technology is and equipment is important, obviously. But it does come with a high direct cost. That obviously has to be paid for somehow, right? Depending on what you're going to be able to purchase and what your company, what your program is looking for, It's essential to be obviously stay at the curve and make sure you're doing the most up-to-date therapies. So technology, in honesty, someone told me, Joe Cicigno once told me, the best technology is the one you have. So utilizing and optimizing what you have is the most important. But when it comes to FTEs, it really comes down to someone who is the most skilled at what they do.
Can you hear me?
Yeah, we're talking about the FTE component of that last question on staffing.
Yeah, I'm sorry about that. Well, I think that what I would say is that the most important part of that is, making sure you're doing things that are specialized. We typically try and take situations with regards to staffing that we want to make as many people as possible do as many different jobs. So, typically what we try and do is say, well, we can put different people into different positions and say that, staff can be flexible, which is great. But what you end up seeing is that people who are not specialized in certain procedures end up taking longer to do them. It takes longer to learn how to do them. And in all honesty, most of the times, if they're not that interested in doing the specialty, they'll learn something and move on. Really what we've tried to do is say, look, if you're going to get an FTE for us and you have to go to the hospital to it, you have to have a plan. You have to say what the goal of that FTE is, where you think the profit will be, how you think the fact that having that FTE will improve your outcomes or volume. And then finally, you have to advocate for having specialty. If you say that someone is dedicated to doing a certain job, like a respiratory therapist who will focus only on pulmonology or IP, you can advocate and say, look, this person only does this. They're able to do it efficiently, quickly, and it improves their volume. And if you ask for sharing FTEs, like sharing nurses and endoscopy suite, it really doesn't move your program forward. It just, again, gets you doing procedures, but doesn't actually optimize what you can do as a program.
Yep. Well, actually, that response dovetails really nicely into the next question that I got, and it was, do you have a nurse navigator? If so, for screening or incidentals, and how did you get that role approved? I know you had one and you moved to two. So, not the easiest thing to get approved.
No, so this is, in a lot of ways, I had to use a lot of political capital to tell them this is a good idea. So for our incidental lung nodule program, we said, look, this is what we want to do. We need a navigator to do that because honestly, the volume is too high, and along with our lung cancer screening, and then it was added to our lung volume reduction program. Now, what we were able to show them on a really, frankly, it was a temporary basis, 6 months of having a navigator to see how it helped. What we were able to show them is that honestly, the salary for the navigator, not only for salary and benefits, we needed to diagnose about 14 new lung cancers in a year. And what we were able to do in that first, 6 months, we had diagnosed 10 and ended up adding about 200 clinic visits for incidental lung nodules. So again, I am a big advocate of essentially using financials to get what I want clinically and do what is best for my patients. And that's what we're able to do. So a lot of it is, again, having an economic plan and making sure you can sustain that and show that economic plan with numbers.
Great. I like this next question. You spoke about shifting volumes in the middle of your talk, specifically in the OR. What relationship, and this question says, what relationship do you have with your IRs, your interventional radiologists, who are also performing percutaneous biopsies? So when you think about that nodule, how do you address that, Camp?
So that's a good question. Really what we end up seeing is that you have to, like we talked about, playing nice in the sandbox, do that with IR. So what we were able to say is that, the tempting thing to do is say every lung nodule that comes in, you're going to biopsy as a team. Again, really what you have to say is that's the right thing for the patient, right? If it's a peripheral nodule or there's no lymphadenopathy, that really should be going to IR because, again, it's going to not only improve the outcomes, but it's also going to move patients through the system much faster. What we were able to show them was that, when we started collaborating with them, calling IR and saying, look, what do you think about this case? Do you think you could do it? And saying, look, if you have patients that have lymphadenopathy that you get called about, feel free to send them over to us. And what you end up seeing is that IR and CT body they hate doing lung nodules. And frankly, they're not all that profitable for them either. It takes up a CT scanner, and so meaning that they can't do outpatient CTs, and it prevents them from doing some of the more, profitable vascular cases. So when we actually talked to them about that, there was no issue at all in transitioning more to us. Now, we still have a very good relationship with them. We have them in our tumor boards. We have them with regards to our incidental. Sorry about that. So really what ends up happening is that for patients who are appropriate for us and doing the right thing, it always is the right thing to do the procedure. But if you end up seeing that there's a better way to do it, as opposed to just saying you're doing it to get the procedure done, again, you think of more in a programmatic standpoint and what's going to enhance patient care, but also grow your program in the future. And that really means saying, look, calling the IR folks up, saying this might be a better case for you. Do you mind getting involved? Because, threefold, it comes back to you in the future.
Okay. Now, this next question is about really the referral that comes in for you. And I like this question a lot. What is the balance between incidentals, lung screening, and outside referrals? In other words, what does capturing and managing incidentals really drive when it comes to program volume, and how laborious is finding the incidental and how many get lost to follow-up? So there appears to be a big concern about the incidental finding on this one. And we hear this a lot. So we'd love to get your take on that.
So the challenge is, and again, it's not on our radiologists or on our ER doctors, but most nodules or cancers we see are incidental. It's just a question of how they get to us, right? What we tried to focus on was improving the care continuum. And right now, the care continuum is, on average, identification to actually getting to the right person who does the biopsy is about 2.5 to 3 months, okay? Which is just terrible. If you're telling a patient they have a nodule and you're not getting a diagnosis or even identifying what the next steps are for 2.5 to 3 months, that's just a lot on them mentally. And honestly, just from an organizational standpoint, it's bad. So we get a lot of referrals, probably 75% of our referrals are from another physician who's gotten a patient with a lung mass or a lung nodule that was incidentally found on a CT scan, or they had chest pain or some shortness of breath. They weren't necessarily looking for lung cancer, but they ended up finding that based on another symptom. So the other 25% or so, with regards to the volume we're seeing, are patients who come into our lung nodule clinic. So we end up in order to have an incidental lung nodule program, we had to have somewhere for these patients to go when a nodule is identified. So we've created our own kind of criteria based on Fleischner criteria. And we said if a patient was identified as having an incidental lung nodule through our ER, and it was less than 6 millimeters in a low risk patient, they actually went back to their PCP. For example, a 25-year-old girl who lives in Indiana and grew up in Indiana and then came to DC, the risk of that is low, and more likely a granuloma, they would follow up with their PCP. Someone who's 6 to 8 millimeters who had higher risk would go to a community pulmonologist to get follow-up, because that nodule deserves to be followed in 4 to 6 months to ensure it's not cancer. If you end up looking at someone who's greater than 8 millimeters at high risk, or not even high risk, they would go to our interventional pulmonology clinic. That was developed, honestly, the incidental lung nodule clinic, once a week and run by our NPs, who would able to triage these patients, see them, and if there was concern or think they needed a biopsy, they would consult with us as well. So, I think that in a lot of ways, our incidental lung nodule clinic is pretty much everything we do. It's just, are we able to streamline the flow of these patients instead of going straight, to 5 different doctors before coming to us from an incidental finding, is to go straight to us through our Navigator identification, through a kind of an organized algorithm. And that's really what the difference is. By having that kind of shift of making it easier for our patients to get to us, by contacting them when those nodules are found or those masses are found, we're able to actually increase our volume, but also improve patient outcomes at the speed by which they get diagnosed.
Okay, great. This next question is a little bit more on technology. It says, I'm looking to pitch navigation to my administrators. What is the why that I need to prioritize this over other projects in the hospital? So I guess at the end of the day, this person's saying, as we all know, we're competing with other service lines. So really, if I want capital in my Bronx suite, what is my why?
So there's 2 whys. The first one is, which, again, administrators aren't always the most, hot on, is that it's the right thing to do for patients. Of course, they're going to say yes, 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 but we need to be able to sustain it. The second part of that is bronchoscopy, especially navigation, whether it be with a navigation platform, a radial ultrasound, a robot, whatever, honestly ends up being profitable if done in the right way and the right setting. Okay, meaning that the contribution margin remains positive for the procedure itself, irregardless of the actual downstream revenue. But the last part and the most important part is that the goal of these procedures is to diagnose lung cancers early. And frankly, by diagnosing them early, you're able to, that is done through either surgery or radiation oncology. Even though our margins aren't huge when it comes to bronchoscopy, the margins for radiation oncology and thoracic surgery are gigantic compared to what we do. So every cancer that gets resected ends up being about $17,000 to $20,000 if done minimally invasively from a contribution margin standpoint.
Wow.
So, the first approach is, yes, it's the right thing to do for the patient. The second approach is it's profitable for the procedure, but more importantly, it's part of growing a program and a thoracic oncology program that even though we don't have those same contribution margin or profits, we have partners such as radiation oncology and thoracic surgery who really do have that profitability. And that's how you build a program from ground all the way to the actual resection.
Love it. Great, great. And there's one last question here. This is a very generic question. And I think we kind of covered this, but what does it take to start a program from the get-go, and what should we be considering when starting our program? And this is obviously from someone that's really starting from ground one. So I guess they're asking, What would you prioritize, right?
Yeah, so I think that when there's a mentality towards it, and then there's the equipment towards it, right? The mentality is that you're going to do the stuff that people don't like doing, whether it comes to biopsying lung nodules, seeing patients when, for pleural effusions, doing those procedures that, one, people aren't that comfortable with, and they don't love doing because they're not comfortable with. So you have a unique skill that if you feel comfortable doing them, you're going to beat out half of the people out there. The second aspect of that is when you talk about equipment and what you can provide, there's only so much you can do with a basic bronchoscope, right? As opposed to just doing infection kind of cleanups or identification.
Yep.
Really what you need is something advanced, and the basics honestly end up being an EBUS system and a navigation system. With those, you can honestly diagnose cancers, stage cancers, and provide the data you need to your thoracic oncologists and thoracic surgeons to actually make a decision and grow that program. So you don't have to have all the bells and whistles of being a therapeutic bronchoscopist. You don't have to have lung volume reduction. You don't have to have lung cancer screening. You have to be able to provide a service that has a gap in your community. And most of the time, what that gap really is staging and diagnosis of lung nodules and lymph nodes. So if you can start there, provide the service that people aren't offering, and be better at what you do compared to other people, you can really go a long way in interventional pulmonology.
Yeah. Okay. That's awesome. I think that's it on the Q&A. We had a good number that rolled in. Here we go. Here's one more. It says, my organization just purchased 3 nav systems for a 40-mile radius to be placed at multiple hospitals. Wow. Now our surgeons are looking for capital investment for robotic surgery. Is there superiority between the 2 platforms? Is this a good thing? Currently, our volumes do not justify 3 nav platforms.
Holy cow, I want to be part of your system. They're buying 3 nav platforms.
Yeah, I know.
So I'll say this, I don't, the administrative standpoint usually is you need to show us the volume before we'll buy these things or plan on program growth. The other approach in a lot of kind of, in all honesty, visionary systems will say, look, if we buy these for you, can you find the volume? So, all those things are in front of you. And like I said, the best navigation system is the one you have, okay, and how good you are at using it. So I think that when you look at comparing the different, first of all, navigation systems, it all depends on what you're looking for and what your institution is looking to do. If they're saying, look, we want to be completely robotic, there are options for that. Doesn't mean it's the best approach. It just means that's what they're going towards. When you're looking at robotic surgery programs, those are becoming more popular in general because of the minimally invasive nature of it. But what I would say is that if you're lucky enough to be in a system where they have the capabilities of having revenue to buy what you need, you still need to show them incremental growth and show them a plan. It doesn't mean you're going to do 100 navigations in a year, but you do want to tell them they need to be able to do the marketing and build up the referral system so that you're able to use those systems and develop them over time. Because the last thing you want to say is overshoot your volume. And then they say, well, we bought all this stuff for you. Why aren't you using it? Be realistic, undershoot. And then as the programs grow and the marketing improves, you can show that you need more information or more data to make those marketing decisions, and your volume goes up. I would, when people buy when they buy devices, but they don't have the volume, it can be challenging unless you have an administration that understands that these programs take time to grow. But over time, in congruence with a robotic surgery program, the profits are going to be there and the volume will continue to grow, especially if you don't have other competitors in the area.
Great. So I guess that question, when I read it, I think, we've got 3 new nav systems, how is that going to coexist with the robot? Yeah. So if a robot's down in the OR and you're doing now Bronch in the Bronx suite, then there's probably room for both. I mean, if they're already there, but at the same token, they might all play their own role, no?
I think that in those situations, it really depends on how the physicians want to do it. You could be creative with that in the sense that if you have a good relationship with thoracic surgery colleagues, you could say, look, are they interested in doing some of these procedures as well to increase the volume? But you can also be in a situation where you have a multidisciplinary approach. You see these patients in clinic together. You show that you guys are very integrated in different places. And you have the ability to say, look, if you wanted to do some of these, the OR, do the diagnosis, do the staging, and do the surgical resection at the same time, if you have that capability, skills, and resources, it's just a different way to promote your program. So you're right, Tim. I mean, there are different ways to kind of utilize that, but it really depends on the creativity and the resources that the institution is going to give to the physicians, both thoracic surgeon and interventional pulmonologist.
Yep. Okay. And then someone here just asked, any chance could I get the algorithm for incidental nodule program? I started lung screening program. Now I want to focus on incidentals. I don't know. I mean, do you have anything specifically mapped out to that yet, or is it too early in the game?
So we have a paper hopefully coming out in the next couple of months, but there is a Fleischner criteria for incidental lung nodules. So actually, I can send Tim the citation, but it's actually very good. It's a little complicated, but we kind of distilled our own down that's similar to that, and it's been working very well. So I'll send Tim that citation to get out to everyone.
Okay. We are in the process of setting up a lung nodule clinic, and we have a respiratory therapist screening the patients utilizing a questionnaire from Lung Cancer Screening Registry, which is the ACR. Is there any suggestion in starting our program?
Part of it is honestly flexibility, saying that, being open to anyone who wants to be seen for a lung nodule. I know there are algorithms that will tease out the ones that are higher risk, but also remember the lower risk ones need to be followed as well because of whatever pathology that's going on. So I think initially, as you're developing those kind of clinics, you honestly have to take everyone. Last Thursday I was in lung nodule clinic, and I saw 4 patients who were all low risk, but they had lung nodules between 8 millimeters and 1.2 millimeters. And frankly, they still needed to be followed for whatever underlying cause it was, mainly because they were 2 of them were Asian females, and they have a higher risk of having non-smoking related lung cancers. So I would say that the algorithms are great, but being available, open to taking new patients, and even seeing patients for a peace of mind checkup, meaning saying like, look, this looks fine. I'm not worried about this, but this is something that I'm glad we showed so you don't have to continue to worry about it, is important. The algorithms are great, but remember, incidental lung nodules, the majority of those are going to be benign. It's more of a question of getting the nodules in expeditiously and being seen quickly so patients don't get lost in the system. Because right now, about 30% of lung nodules that are seen in the ER nationally are actually followed appropriately. So it doesn't have to be finding new cancers. It just has to be making sure that these lung nodules are given their due diligence and followed appropriately for at least 2 years.
Yep. Okay. And then this next question that just rolled in is a very deep economic questions, and I like this a lot. One of the economic drivers that administration is concerned about is asset strength and asset utilization. How does the implementation of a comprehensive lung nodule program enhance a hospital's asset strength and or asset utilization?
I think so. That's a great question. I think what you end up seeing is that, again, it has to do with how much you're willing to invest in the program, first of all, and what kind of roles you have already. So, for example, if we're talking about what we're capable of and the resources we have, it doesn't mean necessarily taking a new FTE and building it into your program. To show that it's sustainable in the first place and successful, you do it on a temporary basis. And that's what we did. We took one of our RTs and said, look, we can take our RT and see how she does for 6 months in doing a part-time role as a lung navigator. Once you saw that our volumes were up, our identification, our speed of biopsy was up, then we were able to say, look, this RT has been effective. Let's put together a full FTE. So a lot of that means is that showing an institution that is sustainable and is profitable on a temporary basis, on a trial basis, by using the resources you already have. And frankly, I think that's how you really show work. If you just say you need an FTE for something, they give you the FTE and the cost of that FTE doesn't work out, then you're kind of stuck holding the bag. In this case, you take an idea, you find people who are interested, utilize it, and then move forward if it's successful. If it's not successful, you haven't really lost anything in that situation.
Yep. Awesome. Well, that was the last question, and we are approaching the top of the hour. Unless somebody wants to come off mute and throw in one more question, I think we're going to wrap things up. So I want to thank you, Dr. Mahajan, for your participation, and for everybody in logging in. For some of you on the East Coast, it's time away from family. For those of you on the West Coast, it's time away from the patient, and we appreciate both. Again, the QR code is here. You can see displayed on the slide. If you want to take a picture of that with your cell phone, and please fill out the questionnaire. We very much welcome your feedback and your input. We again apologize for the technical issues, but hey, it's 2021. The world's an imperfect place, and Zoom is just one more example of that. So, but if there's nothing else, I think that we're just going to sign off. Jody, you have anything to add?
Great job, everyone. Thank you, Bobby, for your help and participation this evening. And everybody have a great night. There'll be a recording sent out on this coming out to you via email soon. So again, thank you for your participation tonight. Hopefully it was valuable. And Bobby, always appreciate your good words, your pearls of wisdom, and your talk track. So thank you tonight for your assistance. Take care, everybody. Have a good evening.